So, good afternoon, good evening, good morning to all of you, dear colleagues. I will start the day with the statement from the DFOOT International President, Dr. Zulfikar Abbas. His message was to the Ministry of Health. The President of DFOOT International urges the ministries of health globally to work together to prevent needless diabetes-related amputation, working in a line with mission of DFOOT International. I am Dr. Salma Khrebat, a diabetic foot surgeon, head of unit at Jaber Al Ahmed Al Sabah Hospital. It is one of the biggest hospitals in the Middle East. It's one of the fifth biggest hospital in the Middle East and the biggest hospital in Kuwait. And I'm expert in the diabetic foot since 2002. Vice President of Diabetes, Diabetic Foot Wound Association of Kuwait, the WAC, and the Vice President of Diabetic Foot and Wound Chronic Association, member of DFOOT International, representing Kuwait, member of ALPS, American Limb Preservation Society, and I'm interested in teaching, education, and hyperbaric. Today, I will moderate and meet and time check for the speakers. Please, Dr. Abbas, President, you can start your
Thank
talk.
you very much. Thank you very much for a warm welcome. I begin in the name of Almighty Allah, who is the most gracious and most merciful. As you said, good evening, afternoon, or morning, wherever you are in the world, greetings and salams to all. It is really great pleasure and gratitude that I address you as a DFOOT International President, which is based in Belgium. We have a recorded message for 3 minutes, and maybe Zaima, you can start to play that.
It is an honor and privilege to address you today as President of DFOOT International. I speak not only to the diverse and vibrant individuals present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related foot complications. DFOOT International is an organization consists of people working in the field of diabetes-related foot complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive foot care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including foot related complications, which is our focus of action here at DFOOT International. Our mission of DFOOT International is resolved and clear, ending avoidable lower limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare professionals are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFOOT International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFOOT International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of DFOOT International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, D-Food International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Thank you very much to everyone. Back to you, Salma. Thank you.
Amazing, Dr. Abbas. I really enjoyed it. And today we have the unique opportunity to share our knowledge, exchange ideas and collaboration on strategies, and improve the lives of those who are affected with diabetic foot and complications. Your participation and engagement are crucial, and we look forward to work together when we have a positive impact. We have an exciting lineup of speakers in the presentation that will provide valuable insights into the latest research, treatment options, and preventative measures in diabetic foot problems. I encourage everyone to actively participate and ask questions at the end of these sessions. Once again, thank you all for your commitments, and let's make the day productive and inspiring. One more brief thing, Dr. Zulfaqar is Abbas, President of D-Food International. He is a diabetologist from Tanzania, and he has experienced more than 30 years in diabetic foot care. He has been honored with the prestigious honor, founded multiple international organizations, and published many researches. He is committed to global health, has earned him multiple awards for outstanding contribution in diabetic foot care. Amazing achievements, Dr. Abbas. And our co-moderator, Dr. Zahid Mian, is the chairperson of MENA region, a council member of D-Food International. He's MCPS, MD, medical associate professor of medicine, director of diabetologies and endocrinologies, head of Department of Diabetic Foot Care, president of primary health care, project director of the Fast Track Pathway, and many, many others, associations and activities. Excellent achievements, Dr. Zahid, and looking forward that we can copy you as we try to work with you. And we'll start our day. Our first presenter, Professor Mohammad al-Makki. He is a FRCS professor, surgery, University of Khartoum, director of Jabir Abuli's Diabetic Foot Khartoum Center. Please, Dr. al-Makki, the floor is yours. You are unmute, please. Still muted, yeah.
Thank you, Dr. Salma, and hello, everybody. I'm really very happy to participate in this meeting. The title of my talk is Initial Surgical Debridement in Acute Florid Wound Sepsis. The presentation should have been, can I have the next slide, please? The slide show.
A second.
Can you see slides?
No, not yet.
Oh, nothing.
Dr. Makki, you should press share screen. It's a green window down in the middle of the screen from down. It's green. It says share screen. Please press on it, Dr. Makki.
There's an arrow on that.
You have the presentation, Dr. Salma?
Yes.
Green. Green. Okay. Mhm. Well, I sent actually the presentation so that I asked them to load it and then. Okay. Mhm.
This is yours, Dr. Makki. This is yours?
Yes.
Yeah.
Where is-
Okay, we can-
Yes, that's right here. Thank you. So initial surgical debridement in diabetic foot Florid sepsis. This presentation, next slide. Can you move the slide, please?
Yes.
That's right here. Well, this presentation supposed to be from Jabir Abul Is Diabetic Center in Khartoum, but unfortunately, because of the war, it is now being closed. And good. Disappear again.
It's showing it just time lag.
Okay, fine. Okay, fine. So this is supposed to be from Khartoum, is a Jabir Abul Is Diabetic Center, which I established in 1998. So last year, when the war started, actually, we are preparing to celebrate our Silver Jubilee animation, but unfortunately, that was the case. So the center has been actually started 1998 with sending 3 surgeons and 4 nurses to King's College Hospital. Thanks to Professor Michael Edmond and the late Ali Foster, because they really have done a great job. Each of them stayed for 1 month. And then we started this diabetic center, as you can see in this slide. It's a multi-center, multi-purpose. You get all the clinics. It is an outpatient sort of hospital. And we have everything. I mean, we have the nephrology, dermatology, ophthalmology, everything. And as the food part, we have all the subsidiary, services. Next slide, please. Well, this is Ali Foster dressing room. As you can see here, we have got 6 cubicles for the dirty wounds, and we have got 4 cubicles on the other side for clean wounds, and we have got 2 for penicillin-resistant and Pseudomonas. Well, this is a shoe factory, which we have had it with the foot care. So each patient, when they come, they have the podiatric services, and then they have the proper shoe, and even the limb prosthesis can be really formed here. Next slide, please. Well, I think the good thing about Jabir Abul Is is that we have started training to open similar food centers in all regions of the Sudan. As you can see here, we have got 7 regions that has been actually trained. And this was supported by the World Diabetes Foundation. We have these surgeons and health professionals. They come for 3 weeks, actually, full-time. Don't go to this slide. But still on the previous one. That's right. So these are the services now being given after this war, because Khartoum has been closed. And may I salute those in the eastern part of the country, Dr. Samit Dirdiri and Dr. Ammar in Port Sudan, Red Sea State, and Dr. Atif Sabil in the North State. And then in the Nile State, where I stayed there for 10 months. And next slide, please. You can see on the next slide, this is the entrance of Nasruddin Karamallah Diabetic Center. Nasruddin is a diabetic who died actually a few years back, but actually he helped us because when we train people from this place, he established this center. It's very crowded at the state here. We usually see around 40 patients a day. And I think they have been done a great service on this. Next slide, please. Well, the good thing about the diabetic patients in Sudan is that the majority are neuropathic. I think around 80% of the patients we see are neuropathic. The neuroischemic are around 20%. Next slide. So we call it usually diabetic septic foot, in spite of the word, it's called diabetic foot or diabetic foot ulcer or diabetic related, but because patients usually present with Florid sepsis. And you can see in this slice, the most common cause is the sharp thing. You have got a needle prick or a thumb prick or a foreign body. And the next is the blisters, which is very common, the blister due to heat or probably the tight shoes. And unfortunately, when you have got a prick of this, no, don't go to the slides before. When you have this prick, usually it implants the bacteria deep in the muscles of the foot. Probably that there is swelling, hotness, and tenderness. And this usually, diagnostic that there is downstairs a strong foot sepsis. Next slide. As you can see here on this dorsum of the foot, this is what you call a cellulitis, but we would be very careful and cautious about this because in the majority of patients, I think in this patient, probably they have already had some antibiotics. So if you find this, I don't think we're going to the argument if this is an abscess or this is cellulitis. If it is swollen, tender, and I think the best thing here is to do a longitudinal incision under local anesthesia. You just need 2% xylocaine with 10 mils of saline, and you can make a longitudinal incision, and that will make really a good relief to the patient. Next slide. As you see here, this is probably very gross, and this patient, I think, is really lucky because you can see in the next slide how much this can happen. Next slide, please. Well, this is what I mean. A longitudinal incision, be careful about the dorsalis pedis artery. You can press on either side or probe your finger, and that will be probably enough. But if you don't do this, next slide, please. This is the situation happening, that you will get gangrenous of the toes in spite of good circulation. This patient has got dorsalis pedis, posterior tibial. They are very good, but because of the high compartment pressure and the digital vasculitis, you get gangrenous of the toes. And this really, we are very encouraging incision to relieve the pressure and save the toes. Next slide. It's quite obvious, you can see here, quite obvious that the leg is also swollen. And in this situation, we extend the incision up, probably up to the knee. It's also done under local anesthesia. Next slide. As you can see here, this patient had a very long incision, and there was pus, and I think it took him probably more than 6 weeks to heal. Sometimes we make a stitching. Next slide, please. Yes, I think we be very careful about stitching. We make it in stages, marginal, and then every time we close it so that we'll avoid any sepsis. I forgot to tell you, on this patient, when they come, you have to investigate the patient for hemoglobin A1C, creatinine, and anemia, because some of these patients might come when they have got probably a renal problem. Well, this slide shows the other side, a plantar surface, which is very common. And in all situations, diamond look for an opening. You will find a small opening and you can probe it. And then you follow that and you open it under local anesthesia. So you might find many tracks. So we call it an open book regimen. Next slide. This is an arterial probing, so you open it. Next slide. Yes, and you can see sometimes we put gauze, and sometimes even we traverse the ankle joint. And in all times, you have to take tissues for culture and sensitivity. And this is a problem because, this is very rather expensive sometimes for the patients to do. So blind therapy is very common. Next slide. Well, just advice about gangrene. Sometimes you get skin gangrene, sometimes you get the whole thing black. But if the patient has got good pulsations, don't sacrifice the toe. You can shave these black tissues and find sometimes very healthy granulation tissue underneath. And yes, next slide, please. You can see here, this is a boneless toe. As you can see, there is osteomyelitis. And when we have this opening, we found that most of the bone is actually shriveled. So we just take it out. And actually, we had a publication on this of boneless toes. And sometimes you just stitch the toe, and that will be okay. So I think a lot of toes being amputated unnecessarily in patients with good circulation due to delay probably in making these incisions. Next slide. Well, this data here will show, in actual fact, we'll study about 138 patients, and we found that actually the rate of major amputation was 11%, which is really, I think, reasonable. So in conclusion, Mr. Chairman, I think that, as you mentioned, I think health education advocacy is the most important aspects in management of the diabetic patients. And this is what we have done actually. Next slide. Last month, we had a trip to the North State and to the Nile State. And we had two nurses from 10 towns, from 7 towns. And then they have a 7 days week, morning lectures, and afternoon dressing to see wounds dressing and to see foot care for patients diabetic without foot care. And they have been told, I mean, we have given them a sheet so that when they go back to their places, they are supplied with the basic things. Unfortunately, I don't think we have 10-gram monofilament for this or Doppler machine, so they will depend just on probably examination locally. And we are going to follow them after 3 months. And I think this is an open area for some help or donation if we can get 14 monofilament nylon, we can get Doppler, we can get autoclaves, and that's basic things. And we have been monitoring them by WhatsApp from these 7 centers in each of these states, so that they should record everything. They have been given a sheet about, and they have been given an address to the patient, so they have 2 or 3 contact telephone numbers, mobile, which is easy, so that we can see. And we ask them actually to approach the diabetic, not to concentrate on patients coming to them. I mean, they have to really go and see all the diabetic clinics. And I think we use the media here that every diabetic should report to these centers to have a foot care, which is very simple, and to be advised about what to do. First thing is to avoid these injuries, which I said. Second thing is, if it happened, what can he do at home? And third thing, where he can go, because another place is that they might go to just local wound healers, and this is really a major problem. Thank you, Mr. Chairman.
Thank you very much, Professor Mickey, and it was really amazing hard work and struggle you've been facing, and amazing results. We'll go now with Dr. Jamil Al-Halabi. He's a surgeon, diabetic foot expert, UMA member, AP member, ADFS member from Lebanon. Please, Dr. Jamil, it's your time.
Thank you.
The floor is yours.
Thank you for the very nice webinar and all your efforts, Dr. Salma. My talk is about severe diabetic foot infections that at the beginning, they may look hopeless. So never give up on apparently hopeless diabetic foot infections. Why? Because medical surgical skills can reverse the prognosis.
We cannot see your slides, Dr. Jamil. Dr. Jamil, we cannot see your slides.
Why?
Nothing there. If you can send them to me now, we can share them.
Can we share the slides? I don't think they are shared.
It's fine.
Yes, nothing now. Yes.
Okay. So The title is Never Give Up in Hopeless Diabetic Foot Infections. Why? Because medical surgical skills can reverse the prognosis. Hopeless diabetic foot infections may look hopeless at first sight. They may look severe, they may look advanced and disgusting even, but despite all of this, they may be salvageable. And this is the important point. So in such cases, how can we avoid preventable amputations? The second question, what are the decision-making indicators to preserve or to amputate? And the third question, what are the salvage strategies? In my talk, I will answer the three important questions, and I will share two real-life clinical cases. The patient is not septic, don't jump to the final decision. Don't commit yourself by saying amputation. Take a bit of time, not too much time, to assess and think. Mark the skin level by drawing a line around the hot erythematous area. And start by securing good tissue cultures, not swab cultures, and immediately or as soon as possible incise and widely drain any collection if present. Just like Dr. Makki from Sudan showed in his slides. Immediately start maximal empirical parenteral antibiotics. My usual choice is TNI and teicoplanin in very severe cases. Then I de-escalate according to antibiograms. Take 1 or 2 days for workup and observe the early response to the treatment. What is the emergency workup in severe diabetic foot infections? CBC platelet, most important is procalcitonin, CRP, and creatinine, not to hurt the kidney of the patient. All of them must be requested in the initial blood test, then used repeatedly in the follow-up. Deep tissue culture should be taken, a good vascular assessment using a manual Doppler if an arterial duplex scan is not readily available, an angioscan to the lower extremities if the creatinine is normal. For the foot, MRI is best for the foot and ankle, with gadolinium if the creatinine is normal to rule out abscess collection, osteomyelitis, and if necrotizing fasciitis is suspected or present, CT scan will give us a better imaging for the gas distribution in the foot. What to do? If the patient is in septic shock or if the patient is in severe sepsis, then we go for amputation. Why? Because saving life is a top priority and we will not risk a life to save a foot. But if the patient is in early sepsis or severely infected but not really septic, the decision of preserving or amputating depends on the age of the patient and the mobility. If he's bedridden, why to do a lot of efforts and to spend a lot of money to preserve a useless foot? The patient comorbidities, vascular condition of the affected limb, clinical and biologic response within the first 48 hours. If the fever and chills subside, if the white blood cell and CRP go down, we will continue. If not, if he is worsening, we will go for a radical treatment. Hotness and erythema regression around the initial skin marking, swelling evolution, and most importantly, if the swelling spreads proximally or if it regresses distally, and absence or presence of crepitations to rule out necrotizing fasciitis. So in severe infection, think first, don't react, act fast and do not compromise. Stick to surgical standards. The knife in our hands should follow the brain, not the heart. We will not economize on tissues. We should be aggressive. Parenteral antibiotics alone are not enough, though necessary. Pending culture results, we should use the most potent parenteral antibiotics. And when we have the antibiogram, we de-escalate. One very important thing to say is the best infection control tool is our knife. And this is what I call knifamycin, to say that the knife is like an antibiotic and much more potent than all. Intra-op, I cut in clean tissues. I don't like to immerse the knife in pus. Avoid small incision and go for excisional incisions. We widely unroof infected areas and then go in the depths, debride, keep on debriding until we get viable tissues. On the operating table, I should think infection control, not reconstruction. I leave reconstruction for a later stage. What are some, in addition to surgery, some intra-op tricks that I do at the end of my surgery? I use a betadinated scrubbing brush at the end of surgery to brush tissues. I take at the end of surgery also a tissue culture or a bone culture if I have a minor amputation from the final wound bed to see if there is residual infection or not. I use profuse pressurized irrigation to wash out the operative field because irrigation will minimize pollution and infection. The solution to pollution is dilution. I fix a catheter or a medicath inside the open wound bed and I attach it to the 3 liters of physiologic saline and I leave it for continuous 24-hour irrigation. Then I detach it from the wound bed the second day. I use wet to dry dressings with or without silver sulfide diazine or medical grade honey, and I avoid tight wrapping material. In addition to surgery, what are the helpful tools? Insulinization is a must to achieve a tight glycemic control. Transfusion is if needed. Hyperbaric oxygen therapy, especially in cases of necrotizing fasciitis and crepitations. Twice daily wound care and daily curating with frequent debridements to make this chronic wound acute again. Negative pressure wound therapy if indicated and affordable by the patient. Better not in the first few days to keep changing on dressing and minimizing pollution. I change the foam every 2 days in the first weeks, not every 3 or 4 days. Keep an eye on the aspirated material if it is very thick, if it's a profuse amount. So from a qualitative and quantitative point of view, and add immunonutrition, vitamin C, zinc, glutamine, and arginine. For the sake of the time, I will present only 2 real-life clinical cases. The first one is a 48-year-old diabetic, poorly controlled man who presented with early sepsis due to a penetrating, you can see the penetrating in the left picture, left up picture, you see at the base of the big toe, the penetrating injury. All the dorsum of the foot was undermined. The infection was spreading to the plantar aspect of the foot. You can see on the MRI the deep pus reaching the metatarsals and even the tarsal bones. On the picture on the right side, we can see the tarsal bones that are just overlying a lake of pus. So I incised both the plantar aspect and the dorsal aspect. You can see in the middle picture, the tunnel where I inserted my index finger to guide the dissection. And on the right hand figure, you can see the pus that is going out profusely. From the dorsum of the foot, I started with the entry point of the foreign body. Then I dissected down to the tendons. I dissected every single tendon out of the tendon sheath, relieved the pus, and this is an aspiration catheter, a tracheal aspiration catheter that I fixed in place. And I connected this tracheal catheter, this aspiration catheter, to a 3-liter bag of normal saline, and I left it to wash the wound for 24 hours. When the surgeon is satisfied at the end of the surgery, the result will be positive. This is how we started on day 1 post-op, after 2 weeks, after 1 month. And this is the dorsum of the foot after 1 day, after 2 weeks, and after 1 month. Then the patient was poor. He could not afford negative pressure wound therapy. So what I used is pure traditional wound care using wet to dry dressing and some ointments. And you see the progression of the healing and cicatrization. Also for the dorsum of the foot. And this is after 4 months, how the wound looked from the plantar aspect and for the dorsum of the foot. The second case is an old lady, diabetic. She presented very late. You can see on the first picture on the left side, the toes were really involved with full thickness gangrene, involving also the metatarsals and reaching the tarsal bones. I started with a surgery, and this is how we ended. I was able to preserve 3 toes, remove the big and second toe, and go till the tarsal bones. I don't think of reconstruction at this time. The aim is to salvage the foot and save the life of the patient who was septic at that time. She had moderate sepsis. And this is how she granulated very nicely. I did not use even skin graft because she could not afford. Usually when I reach this stage, I skin graft the patient, STSG graft. As she could not afford, I continued daily wound care. And this is how she healed. We have very nice healing. The lady is able to amputate. I was able to preserve 2/3 of the foot. So, what are the take-home messages? A meticulous, optimized medico-surgical treatment following a radical state-of-the-art surgery. Yes, we can reverse the prognosis in severe diabetic foot infections and even in early sepsis, not at the advanced sepsis. When the blood supply is acceptable and the surgeon judgment is well-balanced and wise, we should never lose time, no compromise on basic principles. The knife in expert hands is the best way to rapidly control infection. The medical team should aggressively control glycemia, anemia, and bacteria. A good immunonutrition is not to be underestimated. An expert meticulous follow-up every few days is needed to early detect any deterioration. And for the word impossible, I can cut the first 2 letters and say impossible when the decision of conservative treatment is defendable. Against preventable amputation is my mission. Saving limbs and saving lives is my lifetime commitment. Thank you for your attention, and please pray for Lebanon.
Thank you very much, Dr. Jamil. It's amazing talk, and definitely infection is the hardest thing we face with diabetic foot, especially in the neuropathic patient. Amazing work, Dr. Jamil. Wish you all the luck and be safe.
Thank you.
The floor now is Professor Mohammad Reza Mohajiri. He's a professor of endocrinology and metabolism research institute, diabetic foot research group from Tehran University of Medical Sciences. I will share his recorded talk, which is he already sent. And if you have any questions for the attendees, you may share it through the Q&A. Dr. Jamil, help me how to share the. Oh, there it is. Okay.
Okay.
Dear professors and dear my colleagues, it is my pleasure to talk about the efficacy versus effectiveness in diabetic food management. As you know, efficacy means doing things in the right manner, but effectiveness means doing the right things. It means that efficacy is an intervention under the ideal and controlled circumstances, for example, RCTs, randomized controlled trials. But effectiveness refers to its performance under the real-world situation, and many factors may affect in the real-world management of the patient. One of them is patient adherence. Patient adherence is essential for treatment efficacy and may affect positive therapeutic outcome. There are 5 dimensions of adherence. One of them is social and economic, healthcare system, condition-related, therapy-related. It means that complexity of the regimen may affect to the adherence of the patient, and simple regimen may affect the better management of the patient. And at the last but not least, the patient-related factors, such as visual, hearing impairment, knowledge of the patient, which may affect to the adherence and effectiveness of the therapy. Patient compliance is another factor that may affect to the effectiveness. Patient compliance means the degree to which a patient correctly follows their physician of medical advice, and it may related to drug compliance, medical device use, self-use, self-directed exercise. For improving the patient compliance, we have to improve the patient education, reducing barriers of the compliance. For example, simplifying the medication and packaging of the therapy, and enhancing the patient-physician relationship, and setting reminder to the patient to use their prescription. For management of the diabetic foods, there are 6 factors, principal factors that may affect to the management. As you know, metabolic control, educational control, wound control, infection control, mechanical control, and vascular control. And I would like to talk about only with the first 2 things. I mean metabolic control and educational control of the patient. There are key challenges in type 2 management. One of them is inadequate glycemic control of the patient. Hypoglycemic events may affect to the patient compliance and reduce the compliance of the patient and affect to the therapy. And the treatment complexity is the important to management of the patient. Complex treatment regimen are associated with reduced adherence of the patient and at the end cost of the therapy. Delaying control of the patient to the management of the diabetes and increasing HbA1c may increase the all-cause mortality of the patient and increase the myocardial infarction risk, which means legacy effect. And for preventing the complication of the diabetes, in the past, we only focus to the blood sugar, but at the present it means and it is recommended that control the cardio-renal protection, use of glucose-lowering agent, and weight management and cardiovascular risk factor management. For example, sequential management of the glycemia cause treatment failure. At the first, for the patient, we use diet and exercise, and then add, for example, one pills such as metformin, and then add another, and all of the time the HbA1c is higher than the recommended. For example, less than 7%. All of the time HbA1c is higher than normal. But when we use combination therapy, for example, fix those combination pills for the patient for control of the glycemic, early use of the combination therapy cause the HbA1c refer to the normal and remain at the normal with up titration and add another drug for the patient, and it means the control of the patient. Another factor is the fluctuation of the blood glucose. For example, suppose that we have two patients, both of them, the HbA1c is 7.8%, but one of the patient, the fluctuation of the blood glucose, such as this that you see in the slide, and the second patient, the fluctuation is smooth, and the fluctuation is less than the first patient. The complication of diabetes for the patient with higher fluctuation is much higher than the second patient with a smooth fluctuation, and for example, myocardial infarction, renal, cardiovascular, even diabetic foot ulcer and amputation is higher for the patient with higher fluctuation, with high blood glucose and low blood glucose. And by using the extended release formulation in diabetes, we can improve the compliance of the patient. Suppose that for the drug, for example, immediate release metformin, we have to perform the dose of the metformin between the minimum toxicity concentration and minimum efficacy concentration. When we use the immediate release of the drug for example, diabetes, the fluctuation is too high. But when we use the extended release formulation for the metformin, the fluctuation is low and it causes improved therapeutic effect. It causes lower side effects, and the patient can use once daily regimen pills, which cause improve the compliance of the patient. Usually, the patient with diabetes have to follow the complex regimen. For example, suppose that the patient with diabetes, it may use more than 15 types of oral medicine, 2 over-the-counter drug, and many injections for example, insulin, and 4 blood glucose. It means self-monitoring blood glucose. A very complex regimen, which decrease the compliance of the patient. Or suppose that the patient only 2 to 4 injections per day insulin. It means that up to 1,400 injection per year, and more self blood glucose monitoring, which reduce the compliance of the patient. It shows that adherence to oral anti-diabetic agent, when we use, for example, once daily regimen, only 80% of the times the patient follow your recommendation. When increase the times of the drug, for example, twice daily regimen, it decreased to 65% of the time that the patient follow your regimen. And when increased to 3 times daily regimen, it's decreased to less than 40% of the time that the patient follow your instruction. And in systematic review showed that the adherence with medication of the diabetes is only 62 to 64% of the time that the patient followed our recommendation to use insulin or oral hypoglycemic agent. Another problem is educational control. For educational control of the patient, there are 5 key elements of diabetic foot education. One of them, identifying foot at risk. Second, regularly inspecting the at-risk foot. And third, educating the patient, family, and healthcare provider, and ensuring wearing of the appropriate for the patient with appropriate footwear, and at the last, treating the risk factor for ulceration. What is the best educational strategy? By using visualization, we can increase the effectiveness of treatment, and with face-to-face or virtual education, we can increase the compliance of the patient and effectiveness of the therapy. And using the meaningful network could improve effectiveness of treatment. And at the last, there is the paradigm shift from stratified healthcare toward personalized medicine for diabetic foot disease. Personalized medicine aims to deliver right treatment to the right patient at the right time by decreasing the complexity and the complication of diabetic foot ulcer, I mean amputation. Thank you very much for your attention. Dear professors and dear my colleagues, it is my
Thank you very much, Professor Mohammad Reza. It was an amazing talk. And just a second, there's something wrong here. To me, it was the first time where I see diabetologists who are really interested in looking after patients with diabetic foot ulcerations and their concern of management of diabetes in relation to wound healing. I think it was an excellent talk, and definitely research is doing a great job. Now we go to the second, to the next speaker, Dr. William Akiki. Congratulations, first of all, Dr. William. And he is a leading podiatrist from Lebanon with more than 15 years experience in podiatry and orthotics. He is an owner of Akiki Medicals. That is an amazing name. He is a clinical activist at St. George University Medical Center in Beirut. Please welcome Dr. William. The floor is yours.
Thank you, Salma. Thank you, everybody, for being here. I'm trying to share my presentation. So, as a podiatrist, non-surgeon podiatrist, we have not much to say about the foot surgeries other than please respect the foot biomechanics, because if you want to avoid the relapse, if you want to avoid recurrent wounds, we need to respect a bit the foot biomechanics. I know that in the Foot International, our aim is always to avoid foot amputation, is limb salvage. But unfortunately, we are faced on our daily basis to some complicated cases that will require surgical approach that is a bit aggressive, where partial or total foot amputation is required to save the patient's life. So in those cases, we need to know more about the foot biomechanics, how it's working, and then how to deal with the with some amputations in order to promote the gait, the good foot gait. So the plantar surface of the foot is, between others, is constituted by the plantar sensors. The plantar sensors are distributed over all the plantar of the skin. We have the plantar cutaneous sensation, we have the joint positioning sensation that are very important factors in the standing imbalance and ambulation of the patient. So the patient is gonna know where his foot or his limb is situated, and he will have the feeling of the surface he's stepping on based on the activation on those receptors. The more receptors are activated, the more information are sent to the central nervous system in order to give information about the positioning and the sensation of what's happening under the foot. Unfortunately, with the diabetic foot, we have an impaired sensation, and then we have the loss of those sensory receptors, and that makes things more complicated for us. So they get the foot is fully positioned on the ground. During this phase, the contralateral foot is on the swing phase, so it's totally balancing, preparing to the heel strike. And then we have the toe off of the same foot we're talking about, where it's mobilizing the first metatarsophalangeal joint. We have different joint motions that are required to have a healthy and normal gait mechanic. We have a 5 degrees of dorsiflexion of the ankle, and then we have 20 degrees of plantar flexion. We have the knee going from a complete extension to a 60% of flexion or 60 degrees of flexion. The hip will extend and flex with a 20 degrees plus or minus during this gait. I have to add that the grade 2, the interphalangeal joint of the grade 2 is working mostly during the toe off. So we don't have to forget that we have to keep always a good motion of the first metatarsophalangeal joint. The muscular contractions are gonna be working in a concentric and eccentric contractions in the trunk and the limbs to improve the efficient walking. So all our muscles are gonna be working. This walking is gonna be impaired by our patients due to neuropathy, the polyneuropathy. We're gonna have hypotonia in different muscles, and then this will give us different pathologies during this the gait. The foot weight transfer is gonna go from the lateral side of the calcaneus and going gradually transferred to the midfoot, and then during the transfer to the midfoot, the weight is gonna be bared by the plantar fascia, and then it will push the foot into a very limited calcaneovalgus inwards. It will go into inversion, the midfoot, and then the weight is gonna be transferred directly to the first metatarsal bone, and then the toe off is gonna be from the grade 2. So the gait impairments are gonna be caused mainly by a limitation in the ankle joint mobility. So if we have a limitation in the dorsiflexion of the foot due to, for example, due to a shortening in the Achilles tendon, a very severe contraction due to neuropathy of the gastrocnemius muscles, we will have an achinus in the foot, and this achinus will impair the foot from getting into a full dorsiflexion or a half dorsiflexion, and then we're gonna impair the gait motion in the heel strike faces, and then the patient is going to have a heel strike that is very minimal or absent, and then all the weight is going to go directly to the forefoot. If we have a limited range of motion on the first metatarsal phalangeal joint or other metatarsal phalangeal joint, but mainly the first one, so that on the toe off, the patient is not going to be able to dorsiflex his grade 2 in order to propulse, to give his the weight of his body going forward. And then we're going to see a patient overloading his grade 2. We're going to see a patient getting ulcers on his grade 2, and then it's going to make things more complicated for us. For example, if we have this toe amputation, this patient had to go in the first picture that is in the top. This patient foot was saved by the surgeon, and then they kept a minimal invasive. I mean, by minimal, that is they are trying to keep what is intact, the normal toes that are intact, they are kept in this surgery in order to preserve the maximum parts of the foot. But for example, this patient is going to have a problem with the relapse since his grade 2 is not flexing dorsally properly. So we have an impairment in the dorsiflexion of the foot, and then we're going to see a recurrence of the wound on the grade 2. And then we can see also on this patient a reopening of the original wound side due to an overloading on the lateral side of the foot because his grade 2 is not dorsiflexed during the toe off of the gait. So the question that I ask myself, and every surgeon in my opinion should ask himself, is should I remove all the toes and get into Lisfranc or transmetatarsal amputation? It's a very hard question to answer, and then it's very hard to convince the patient, since the patient is gonna say, my grade 2 has nothing, why would you remove it? But actually for us as podiatrists and orthotists, to offload this type of patient is gonna be very complicated and very costly for the patient, since the best would be a full panel of offloading devices where we can have, he should have the custom-made orthopedic insoles. He should have a customized shoes with a rocker bottom. So the rocker outsole will help to get the toe off easier without mobilizing the first interphalangeal joint and metatarsophalangeal joint. And what we need to think about is also at home, where this patient should have custom-made also sandals. It makes him pay and get stuck with devices that will make him, have a recurrent ulcer if he's not wearing them. So after the surgery, the patient is stuck with all the devices where he cannot even walk barefoot. I know that walking barefoot is not good for the diabetic patients, but even for small steps is going to be very dangerous for this patient. So the question I will re-ask and ask myself and ask you to ask yourself is, should I remove all the toes and have a very clean and a clear forefoot, where the amputated foot will have a normal device that can fit everywhere without putting at risk a recurrence of the ulceration at the one side, or another ulceration and going through the same process with the wound healing for this patient. For example, in the picture below on the bottom, we see that the amputation was done so properly and the patient is not suffering from any because those patients were clinically examined. So this patient is not suffering from any any problem in the metatarsophalangeal joints, and then the dorsiflexion is respected. So keeping all the toes and keeping all the mobility on the forefoot is more than recommended for these cases. For example, if we have to go through any orthopedic job to be done on some patients, so we always require, if you can avoid the maximum of fusion on the talonavicular, on the talotibial joint, so we can keep the dorsiflexion of the ankle mobile the maximum, so it will help us removing the pressure from the forefoot. If you want to have any fusion on the talonavicular or the subtalar joint, it doesn't change anything in the gait motion. Sometimes it's beneficial for the patients since it will give them more stability in the hind and midfoot. But the problem that we have to ask ourselves is, should we have any fusion on the first tray? Should we have a fusion of P1 over M1? This is always the question. Sometimes we don't have any other option, but if this option is the only option on the table, as podiatrists, we ask the surgeons to keep the P1, the first phalanges, with a maximum of dorsiflexion. A 10 degrees of dorsiflexion is more than enough for the first phalangia, of the first tray. So it will help mechanically to have a limited toe off. So it's very important for us to see what's happening to look at the aftermath of the surgery. If we don't look at it at the surgery, and then if we don't see what's happening after it, it makes our life difficult. And then whatever we do as offloading is not gonna happen, because the pressure distribution is not gonna be enough, because we need to have a good weight transfer on the. So since the weight transfer is happening properly, we don't have any problem in the fitting of any orthotic for the patients. So this is what we always look at. So as a take-home message, we have to respect the main joints mobility. Don't hesitate to ask and consult your podiatrist. I know that podiatrists are not very common in all the facilities in all the centers in the MENA region, but in any case, if you need any support, you can ask any podiatrist you know on what's gonna be the best, and then it's gonna be repetitive with the patients, with forefoot impairment or rear foot impairment, with Charcot foot deformity. It's going to be systematic for all of them. So I just ask you, surgeons, please always think about the aftermath and the feasibility of the offloading and footwear adaptability after any surgery, or even during the healing process of anyone. Thank you very much.
Thank you very much, Dr. Akiki. It was a very interesting talk. Biomechanics is definitely important in diabetic foot management. Really appreciate your work. And are you thinking of business overseas? We'll answer that later.
We'll see. Actually, thank you again for the opportunity for tonight, and please accept my apology of leaving the panel now, because I have other commitments. Thank you very much, and see you soon.
Okay, see you. Thank you. Good luck. We'll go now for our fifth speaker. Thank you. We'll go for our fifth speaker, Dr. Awan bin Zafir. He is MD Internal Medicine. He's currently serving as Associate Professor of Medicine and Consultant Diabetologist in Baqi Institute of Diabetes and Endocrinology.
Thank you very much. Can you share my slides?
Sure. Again, for the attendees, if you have any question, use the Q&A. And thank you for being patient with us. I know we're a bit behind time. Just we're trying to cope and
Okay. Shall I start?
fulfill our... Yes, go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. This is my first time interacting with you colleagues, and I am honored to discuss a very critical aspect of diabetes care in Pakistan, that is peripheral artery disease. Next slide, please. Okay, this is my introduction. Next slide, please. Okay. Diabetes affecting over 33 million Pakistanis, and PAD being a significant complication, a leading cause of major amputation, mortality, and reducing the quality of life in Pakistan. But unfortunately, it remains underdiagnosed and undertreated in our country. So to address this gap, can you go back the first slide? First, yes. So to address this gap, our institute, Baqi Institute of Diabetes and Endocrinology, in February 2020, we initiated the PAD registry to document and analyze PAD cases in people with diabetes. In recognizing the collaborative data collection, our institute later on subsequently expanded the registry to include 12 affiliated centers across the country. Next slide. So our objectives are to estimate the prevalence of PAD in people with diabetes and to identify the risk factors and demographics associated with PAD, to track the disease progression and outcomes, and to inform evidence-based management guidelines. Next slide, please. So the importance of PAD registry is we can detect PAD cases early, and we can have a good management of PAD patients, and by this we can prevent the amputation, especially the major amputation. And of course, the cardiac events can be prevented. And we can have evidence-based guidelines and valuable insights for the research studies and raising awareness among healthcare professionals and patients. And by this, we can standardize the management of peripheral artery disease in people with diabetes. Next slide, please. So we are collecting the data, including the patient demographics, relevant medical history, the clinical presentation, and the bedside diagnostic tests, ABI and the Doppler ultrasound waveforms, and the treatment and the outcomes. Next slide, please. Our future directions, our aim is to expand this registry nationwide and include all major universities in all provinces of Pakistan, including all secondary and tertiary centers which are providing the services of diabetes. And then to integrate this data into electronic health record. And we will do the data analysis, frequent data analysis, and we can make the healthcare policies. Next slide, please. So what we have done so far by this is an overview. You can see the data up till now from 2020. We had 2,800 patients of PAD, and we have done 356 angioplasty out of them, and all of them they presented with the toe gangrene or the non-healing ulcer of the dorsum of the foot or on the lateral side of the big toes. So patients with primary healing were 73. The patients with ongoing ulcers are 157. And among 356 angioplasties patients, 9 patients were, they end up with the major amputation. And 95 patients, they were improved with the minor amputations. And few of them, they died. 20 of the patients, they died. So this is our data up till now from 2020 to till now. Next slide, please. But we have some challenges while we are making this registry and planning to elaborate our registry nationwide. So these are the challenges: disease awareness lacking. We have skilled professionals shortage, screening insufficiency, inadequate management, high intervention costs, and inadequate data collection. So these are the challenges, but we do have opportunities. Next slide, please. The collaboration with international organizations for the training and capacity building, and the government support, government initiatives to improve the infrastructure, and public education campaigns, and the PAD, local PAD guidelines, the specialized, we are trying to make this, we can develop these specialized vascular centers, and of course the research and the low cost interventions. Next slide, please. So now I am going to show you one real case because I was told that I have to take 7 minutes. So I have put only one case, a real life case, which came to our OPD a few months ago. You can see this is a 60-year-old male, and he presented with a necrotic small patch over the heel area. It was very painful. So on the examination, the pulses were not palpable, and the ABI on the right side was 0.5, and on the left was 1.4. And it was also having neuropathy, the monofilament break vibration senses were absent, and VPT was 50-50. So I just wanted to show this case because what we are doing in our center after getting PAD cases. The next slide, please. So So we did the ultrasound Doppler in our institute. We have a very good ultrasoundologist, and we all know that ultrasound Doppler is ultrasoundologist dependent. So we have trained our ultrasoundologist, and also in our vicinity in Karachi, we are calling and the ultrasoundologist for the training of the ultrasound Doppler to get a better report of the ultrasound. So this ultrasound, you can see we get such types of reports, and very clearly the ultrasoundologist has mentioned that there is a block and monophasic waveform in the distal posterior tibial artery. So after getting this report, next slide, please. This patient was sent to the vascular consult, and we usually send our patient. We have connections with the interventional cardiologists, interventional radiologists, and the vascular surgeons. So because Karachi is a big city and we have multiple tertiary hospitals in our city, so we have made some connections with the vascular surgeons, interventional cardiologists, and the interventional radiologists. So this patient was sent to the vascular surgeon for the revascularization procedure. And you can see in this diagram that there was no flow seen on angiography in the distal part of the posterior tibial artery. Next slide. Next slide, please. After doing the angioplasty by the vascular surgeon, we can see the patency of the posterior tibial artery. There is restoration of the flow in the posterior tibial artery. So after doing the angioplasty by the vascular surgeon, this patient was then sent back to our hospital. Next slide, please. And then the patient came back in our foot clinic to us, and then we debride the wound, and we can see that there is a good perfusing wound, and we can see blood is coming out after, and this patient was regularly coming to our hospital, and ultimately it was healed within a few weeks' time. So there are so many cases with us. Because of the shortage of time, I have not showing all these cases, but this is our way of management of PAD cases, along with the, of course, we are also covering all and aggressively treating the all metabolic and cardiometabolic risk factors, giving the antiplatelets, the thrombolytic agents, rivaroxaban, and high statins. And if patient is hypertensive, we are giving an ARBs or ARAs inhibitors. So, and other supportive management, the metabolic control. So we have made connections. So what we are doing in our institute, so and what we are teaching the all our 12 affiliated centers, if we are making this registry. So by this registry, uh, we can have a good prevalence rate, and we can have a good early diagnosis. We can have a awareness among the healthcare professionals, and we can have our local guidelines, and so that we can manage PAD properly. So what we are doing, we are asking our primary care physicians to make connections with the interventional cardiologists or radiologists or the vascular surgeons, and always classify the wound. And if it is class Sinbad class 4 or 5, and you are suspecting, you have diagnosed PAD and needing revascularization, so you must send this case to the interventional cardiologist or vascular center, where the angioplasty, angiography and angioplasty can be done. And after doing this procedure, we ask the the vascular surgeons and the interventionists to send this patient back to the primary care or the primary foot clinic where the patient can be managed by wound control or by the metabolic control. So hopefully our by this our mission is of course to prevent this amputation rate in our city and across the country. Thank you very much.
Thank you very much, Dr. Owen. It was amazing talk, and definitely our patients are VIP patients, and vascularity comes the priority, second infection, and the third is the pressure prevention. So vascularity is number one. Thank you very much, and I would like to share slides of Dr. Mohammad Kousa. He's a Syrian board-certified orthopedic surgeon. He has master degrees in orthopedic surgery at the Ministry of Higher Education and the Scientific Research from Damascus, Syria. I will share his slides. Just a second.
It will not work. Another version of Teams. The version that the doctor sent you is different from the version you have on your laptop. I think will not be able to display it.
Okay. So I think we'll find a way.
I can do it.
Sorry?
I can share it.
Yeah, okay.
Okay.
Thank you, Zahid.
Problem-solving ability, Zahid.
That's why when we have more than one to
of
share.
Course.
Thank you all for being patient again, and we're waiting for your questions at the end. We cannot hear anything, Zahid. There's no sound.
Can you hear it now? Yeah.
I can share mine now, Zahid.
Okay. Okay. Just share your.
Okay.
Okay.
Good evening. Today I will present some techniques of offloading from our practice in Syria. The two major causes of food ulceration that are widely reported and accepted are proteinuria loss and high or excessive pressure. They are not always fully appreciated or effectively addressed in clinical practice. The reduction of either excessive or sustained forces to localized areas of the plantar surfaces is perhaps the most important clinical aspect of ulcer prevention and treatment. Offloading mechanical tissue stress is arguably the most important of multiple interventions needed to heal diabetes-related food ulcers. Generally, offloading understood as relieving of pressure from an ulcerated area. In truth, this term should more correctly be used to describe the reduction, redistribution, or removal of detrimental forces applied to the foot. These forces may be a major contributing factor to ulcer occurrence, relapse, chronicity, or deterioration. Clinically, it's not always possible to remove all forces applied to the foot. Thus, clinicians must think in terms of reducing the duration, velocity, magnitude, and direction of force or its redistribution. The margins of the feet at tendon prominences are already under a high degree of intrinsic pressure. Offloading is one of the cornerstones of successful diabetic foot ulceration management and prevention. In practice, these are commonly used offloading methods cast devices such as total contact cast, which is the accepted gold standard for the offloading of mid and forefoot lesions, and removable cast walkers with a rigid rocker sole unit are held in place with Velcro straps. If no offloading devices are available, consider using appropriately fitting footwear combined with felted foam as the third choice offloading intervention. Now, this picture shows our lower cost material, which depends on the material of ethylene vinyl acetate. It's a copolymer of ethylene and vinyl acetate monomers. Closed cell foam is a type of foam in which the cells are closed and tightly pressed together, with higher density and greater pressure resistance. In our technique, we use bulk dressing by bandage, EVA insole as an irreversible offloading method. The insole is entitled to fit every patient case, stabilized by bands and adhesive tabs, repeated in every dressing changing. These some cases from our practice. The first case is a female with transphalangeal amputation of hallux. These the bulk dressing, and this the EVA insole. It's cut to fit the foot and perforated for moisture wicking and enhanced ventilation. The patient can walk immediately with total loading on foot after surgery. This another case of a male with first metatarsal amputation with debridement on dorsal aspect of midfoot joints. Plantar offloading and stabilizing ankle joint by using an insole as a reversible cast on medial aspect of ankle. And the patient walks with stable ankle and foot joint after surgery. This case of a female with wide surgical debridement after severe infection on plantar and lateral hindfoot and midfoot. We use the material as a dorsal stabilizer to ankle joint with plantar flexion of ankle. Another case of a male with plantar forefoot ulcer treating with standard of care methods and offloading by modifying insole to protect ulcer site. This show emptying ulcer site and this healing after treatment. Another case, plantar heel ulcer, modifying insole to protect ulcer site and tabs. The sixth case, charcot arthropathy with bony prominence on plantar aspect with modifying EVA insole to protect ulcer from loading forces. This emptying insole on ulcer site and this healing after treatment. This case showing lateral aspect of angle around malleolus infection with peroneal tendons involvement. This infection signs, surgical debridement with resection peroneal tendons and lateral ligaments of ankle, and this healing after cast of walking below knee cast, and this healing. Using EVA and SOL as ankle stabilizing cast to make patient walk immediately with total loading on extremity after surgery. If such non-surgical offloading treatment fails to heal a plantar forefoot ulcer, consider an acute stringent lengthening, metatarsal heel resection, joint arthroplasty, or metatarsal osteotomy. In this case, a man with previous transdistal metatarsal amputation suffering from equinus deformity and chronic plantar ulcers. These ulcers before surgery and these sutures after percutaneous lengthening of Achilles tendon. Total contact cast applying with EVA and SOL for immediately movement after surgery. After 3 weeks from surgery to lengthening Achilles tendon. In cases of prominence metatarsal heats and chronic or recurring ulcers under them, we resort to cutting through the metatarsal neck and leaving it in place while applying our special insole until healing occurs in ulcer. In this case, heat of second metatarsal was cut. Another case, third and fourth and fifth heat osteotomies after 1 month after sutures removal. For healing a neuropathic plantar or apex lizard digit ulcer secondary to flexible to deformity, use digital flexor tendon tenotomy. In this case, acute infection with involvement of the first metatarsal phalangeal joint with medial ulcer after debridement, affected bones, and arthrodesis the joint with Kirchner bend, offloading by plantar EVA and SOL. I would like to draw your attention to this citation from Dr. David Armstrong about Dr. Abdalla method of offloading by EVA technique. And this is a summary of correspondence. I personally like to call it Dr. Abdalla method of offloading. Finally, I would like to thank you very much for giving me this opportunity to participate in this scientific forum under the auspices of DFOOT International. Assalamu alaikum wa rahmatullah wa barakatuh.
Thank you very much, Dr. Mohamed Kousa. It was a very interesting talk, and this is where they had the award from at the DFOOT International as the best service during the crisis. And finally, and not the last but not the least, Dr. Ali Nasser, thank you very much for being patient. And it's okay, from Kuwait to Kuwait, we can be patient together. And thank you for holding on that strong. Dr. Ali Nasser, he's a specialist general surgeon, fellowship in diabetic foot surgery, Maria Cecilia, right? Hospital from Italy. And he's currently working as a specialist at Jabal Sabah Hospital in Kuwait. Please welcome Dr. Ali Nasser.
Thank you so much for this opportunity. Really amazing talks. It was really nice to listen to all of your experiences. Let me just share the slides. Okay, here we go.
Yes.
Okay. So I was hoping to take this opportunity to highlight where we are right now, globally and regionally, in terms of diabetic foot, and where we're headed, and what is needed moving forward. So the title of my talk is Diabetic Foot Surgery, an important field of particular importance to the MENA region. So first of all, I'd like to start by showing you this map. So it's a map showing the estimated comparative prevalence of diabetes in adults in 2021. So it's basically it's color coded, and as you can see, if you look at the key on the left side, you can see the black color represents countries that have diabetes prevalence of more than 12%. So just eyeballing this map, you can easily identify that our region has a really high prevalence of diabetes. especially compared to the rest of the world. So diabetes, as we know, is a universal health problem. It's associated with an ever increasing burden of disease. Globally, it's estimated that 537 million people have diabetes. And what makes this more alarming is that this number is only increasing. So in 2030, it's estimated that 643 million people will be suffering from diabetes, and 2045, this number goes to up to 784 million. So moving on to our region, so the MENA region, the prevalence of diabetes in the MENA region is a public health issue of particular concern. Compared to other region, the MENA region has the highest regional prevalence of 16.2%. And it's estimated that by 2045, this number will increase by 87%. So just just listening to these numbers or looking at these numbers, you can easily imagine how much diabetes causes a strain on our patients, our communities, and on the healthcare. And along with diabetes, of course, comes the complications. And of course, the complication we're most interested in here is foot ulceration. So foot ulceration is a very common complication of diabetes. It's estimated that around 34% of patients with diabetes develop diabetic foot ulcers during their life. And as you can look at this slide, you can see that it's multifactorial, with the main culprits, as we all know, being diabetic neuropathy and peripheral arterial disease. So it's estimated that around 18.6 million people globally each year develop diabetic foot ulcers. And of course, diabetic foot ulcers is responsible for significant levels of morbidity and mortality. So as we all know, diabetic foot ulcers are associated with increased functional dependency, impaired quality of life, and along with diabetic foot ulcers come the complications. So they can range from soft tissue infections up to gangrene, limb loss, and even death. Considering the complex multifactorial nature of diabetic foot ulceration, its substantial burden on the health system and on the society in general, it becomes evident that there must be a comprehensive, multidisciplinary health service dedicated to the prevention and treatment of this condition. So the field of diabetic foot surgery has its roots in podiatric, orthopedic, and plastic surgery. And over the years, this field has evolved into a more unique interdisciplinary specialty, which aims to increase limb salvage. And this has been made possible by integrating soft tissue reconstruction and conservative orthopedic techniques, as well as having or adopting a more holistic approach to the treatment of diabetic foot. So a modern-day diabetic foot clinic optimally operates in a hospital setting. And what we mean by a hospital setting is a setting where you have multiple essential services available, including day surgeries, inpatient, outpatient services, as well as emergency admissions. And the hospital settings also facilitates a multidisciplinary approach. So, for example, if you need to consult diabetology, orthopedics, or vascular surgeon, you have the opportunity to do that. So, what about the diabetic foot surgeon? So a diabetic foot surgeon should master a variety of technical skills, and this includes basic assessment, a thorough inspection of the skin, assessment of foot deformities, and up to comprehensive neurovascular assessment. And in terms of surgical skills, the diabetic foot surgeon should be able to perform a wide range of surgeries. This could range from simple tendon release surgeries, ulcer resections, and go up to flap surgical techniques or osteectomies. And as we saw in the previous slides, most of our colleagues are performing most of the surgeries that I just mentioned. So, in conclusion, the diabetic foot is a complex multifactorial condition with far-reaching implications for both individuals and their communities. So I believe more research and audits are essential in exploring both the burden of diabetic foot and on our communities, as well as the gaps in the current medical services in the MENA region. So tackling this public health concern will require robust knowledge and well-guided physicians, as well as support from the community and the governmental levels that should be essential. And this concludes my talk. It's a quite short talk, but I think it's also really important to understand what are our roles and what are we looking forward to, especially in the future when it comes to diabetic foot surgery. Thank you so much.
Thank you very much, Dr. Ali and Nasser. It's been it's amazing talk, short, and thank you for being sticking to the time. And thank you everybody for being patient again, holding on with us. And any urgent question you may ask, raise your hand and we can open the microphone so we can ask. Any questions? You can click on raise hands and ask a question. Or any of the panelists are. Unmute if anybody is going to ask a question. So, as far as I can see, there are no questions here. Thank you very much, everybody. Thanks for DFOT International and for giving the opportunities for all the speakers to be part of this Awareness Week. And it's been an amazing experience, I'm sure, for all of us and for the speakers and also for the attendees. And looking forward in the future to have further collaboration among the MENA region to have a study-like paper to be published of the and diabetic foot, how it is managed and served in the MENA region. Thank you very much and hope to see you all well and soon.
Thank you, Salwa. Thank you very much indeed. This is my duty to thank you and to thank to the all participants as well, and to our August panelists as well, who spare their time for this session, as which was very interesting, 1.5 hour session, although we are sometime late, but it was very interesting, and that shows how there are many opportunities which are available in each countries to do a lot of work need to be done, and the implementation of the guidelines need to be done in every countries. So thank you very much for all your efforts, Salma and the other colleagues. It's time to say goodbye to all of you. Thank you very much.
Thank you. Goodbye, good night, and see you.